I'm Dr. Bob Laskowski. I'm the president of Christiana Care Health System. I see so many colleagues here. Good morning to you, and so many friends from the community. Welcome to this discussion here this morning. This is our third Value Institute symposium. And I just want to say a couple words a little bit in the context of this. Value is very important for us at Christiana Care. In fact, when I talk about how we make our strategy of service real, I use one word, and that's value. So our strategy for Christiana Care is value. One word. It's understanding. It's a nuance to that, though, in that what we mean by value is understanding what makes a difference to the people that we're privileged to serve, who we call our neighbors. Understanding that in ways that we can operationalize what we do to build systems of care to partner with our neighbors so that they can live the lives that they want to live. So value, absolutely critical for us. And so discussions like that we're having this morning, very, very important for us. I want to do some thanks. I thanked all of you in the audience. I want to thank the Delaware Public Policy Institute for being our partner here, and for John Taylor for leading that institute. So John, thank you for your sponsorship. For those of you who don't know that, the Delaware Public Policy Institute is a group of community leaders who tries to make sure that we in Delaware are paying attention to important problems in our community. So John, thanks again for your leadership. Now, lots going on in healthcare these days, and you can't read the paper without seeing things about exchanges and lots of things about the Affordable Care Act. October 1st was a particularly important day because it was the day when access to care began to become available to many, many of our neighbors that formerly had not had that access. Now, we at Christiana Care are very proud to be partners in the efforts to help our neighbors who didn't have the benefit of health insurance to gain access to that insurance, because we know in that spirit of value, making a difference, doing things that matter for people, that if you don't have access to care, then whatever else you do, whatever other system of care you have, doesn't make any difference. So it starts with access. But access is only part of it. The content of care matters enormously. It's the what you do as well as having access. The access to that first step, the what you do is incredibly important. So if you think then of medicine, our role, I'm a physician, our role as doctors, our role as health professionals more generally, our job is essentially a humanistic job. It is to help people live lives that they want to live. And that is easy to say, hard to do, hence discussions like this, very, very important. So medicine is a humanistic discipline at its core, in which we bring science to help people to live lives that they want to live. So we need to listen to them, and we need to understand what truly makes a difference in their life. Lots and lots of research in medicine, lots of thoughts about how we live, do things which help people to achieve freedom from some very difficult problems and diseases that they have. Relatively less discussion about the how that we live, the quality of the lives that we live, and that aspect of the content. And I think that's particularly important if you think again of medicine as a humanistic discipline. So today we're going to talk about that. We're going to talk about the quality of life and about how we as a society generally, and we specifically in the health professions, can be experts in this area so that we can help our neighbors live the lives that they want to live. To help us to do that, we have a couple of distinguished guests here, Dr. Diane Meyer and Dr. David Casarett. You're going to hear a little bit more about them in a moment when they're introduced. We also have a lot of local expertise. My colleagues here in the room, prominent among those local experts is Dr. John Goodall, who heads up our palliative care section, and John is going to join the discussion here. We have a statement that's hanging around here, the Christiana Care Way. And in that Christiana Care Way, you will see the framework that I hope we have for our discussion here today. We talk about being respectful, expert, caring partners in the health of our neighbors and building systems of care that our neighbors value. So that's what I see our discussion today as furthering. So now I'd like to turn the podium over to a very distinguished colleague, Dr. Tim Gardner, who is the Executive Director of Christiana Care's Value Institute. Tim, all of our colleagues who know him well in the room know that he is a Renaissance man, a internationally prominent cardiac surgeon, director of our Center for Heart and Vascular Health, with a keen humanistic, broad interest informed by science in helping our neighbors to live the lives that they want to live. So Tim, thank you for your leadership, and you can do the introduction, sir.
Thank you, Bob. I didn't expect that particular honor of Renaissance, but I'm glad to have it. Welcome, everyone. We're really pleased to have you here for our third Value Institute Symposium. As most of you know, the Value Institute was started about 2.5 years ago. This is Bob Laskowski's vision. It is the embodiment. We are trying to make the Christiana Care Way mission even more effective by finding out what really is of value to our patients, to our community, to our neighbors, and designing systems of care that our neighbors value. That really is our motto, and it's a very strong one. We just received our new Value Institute brochure, flagship brochure, and an annual report, which is in here. And this will be available for all of you at the end of the session. I think you'll find this, the information provided and the elaboration of our mission statement and the prominence of our team and the strengths that we're trying to develop very interesting. This is an initiative of great importance to us and our community, and obviously, as I said, expresses our vision and our mission as well as any. I also want to thank John Taylor and the Delaware Public Policy Institute for their support, actually for their encouragement to undertake a symposium on this very topic. All right, at our first Value Institute Symposium, John and other members of our community, including Senator Chris Coons, talked about the importance of us as a provider community, as a medical professional community, understanding more effectively how to help people deal with these end-of-life issues. And obviously, this is a conversation that focuses on value for all of us. You know, as physicians and nurses and social workers and other providers, we face daily dilemmas when dealing with disease and with patients at the end of their lives. This is a big challenge for us. Dr. Meyer just gave had a masterful presentation at the Department of Medicine Grand Rounds this morning, imparting some really wise perspective on what that conversation should be like and how we as physicians and nurses and providers need to learn to speak differently and to respond differently. And the humanistic hone was very much there. But families, individuals themselves looking to the course of life, deal with this all the time. What struggles almost all of us have had as we've had to deal with the loss of our loved ones, and how to deal with the responsibility and so on. And so this is highly relevant and so on. Our accomplished and expert speakers are here today to really broaden and deepen our understanding of this complex subject. There are cards at all of the seats, and we would encourage you to write questions during the presentations. We'll have a chance to, we'll have a good discussion period. As Dr. Laskowski mentioned, John Goodall will join our two speakers, and we'll have plenty of time for comments, questions, and reflections on their presentations. Excuse me. We're going to shift the order a little bit. We're going to give Dr. Meyer a little bit of a break after her hour-and-a-half workout with the Department of Medicine this morning, so we're going to start with Dr. Casarett's presentation. So it is really a pleasure to introduce Dr. Casarett. He is the Chief Medical Officer at the Penn Wissahickon Hospice. He's Director of Hospice and Palliative Care at the University of Pennsylvania Health System and is an Associate Professor of Medicine in the Perelman School of Medicine there. In addition to his medical training, Dr. Casarett completed a master's degree in medical anthropology and fellowships in ethics at the University of Chicago and in palliative medicine at the University of Pennsylvania. His major research interest centers on understanding and improving the way that health systems care for patients near the end of life. He's been the primary investigator on major studies on quality of care at the end of life, and he received a Center for Medicare and Medicaid Innovation Grant for a program recently called CLAIM, Comprehensive Longitudinal Advanced Illness Management, a program to improve the care of patients with advanced cancer. Dr. Casarett received the Presidential Early Career Award for Scientists and Engineers, the PCASE Award from President George Bush at the White House in 2006. This is a presidential award given to the country's most promising researchers. He's also author of a book entitled Last Acts, Discovering Possibility and Opportunity at the End of Life, which was published by Simon & Schuster in January 2010. So please join me in welcoming Dr. Casarett.
Thanks very much for that kind introduction. It's a delight and an honor to be here, and particularly in this neighborhood, because although Diane and I come here as experts, I know many people in the audience, and I know a lot of the expertise that you have in palliative care, whether it's people like John who have developed the palliative care service, Jen McElveen, who's a nurse practitioner, Susan Lord from Delaware Hospice. These are all people I know and colleagues who I respect, and they're in your backyard. They're here. So Diane and I will wander back to Philadelphia and New York this afternoon, but you have an enormous reservoir of experience and skills in the kinds of things that Diane and I will be talking about today. So I hope we can add something to the mix, but keep in mind you have a wonderful set of resources here, and we can add to that. But you really are very, very fortunate. I would encourage you both in the discussion period and then in the coming days to seek out the people sitting to the left of you and to the right of you to add to what we can offer. I would also say that I'm absolutely delighted to go in this revised order ahead of Diane Meyer. I've spent far too many of these sessions trying to follow her, which is not in a position that any mortal wants to be in. So this is absolutely delightful. I can give my piece, and then I can get out of the way, and you won't have her presentation in mind as you're listening to mine, unless you were at Medicine Grand Rounds, in which case I'm just toast. I just got back from Nepal. I was there for a couple of weeks. I got back 5 or 6 days ago. And one of the neatest things to me about I was working in a hospice there and then spent some time backpacking. And one of the neatest things about traveling Nepal to me was the combination in a single backpacking day of 15 miles or so, being up on ridge lines and on passes with a view literally for hundreds of miles. But then an hour later, being able to dip down into a valley, wander through a village, being invited into somebody's house for tea. So amazing views you can see for hundreds of miles, but also that one-on-one interaction with folks. And I've got to say that the people in Nepal are among the nicest, warmest, most welcoming of any of the several dozen countries I've been in over the last 10 years. So that was a real pleasure and a privilege. And I wanted to share this picture of Nepal and tell you that story because that's what I'd like to give you in the next 45 minutes or so. I'd like to give you both a combination of that 10,000-foot view, but also drill down and give you a story along the way. So let's start with the story. This is a guy named John who I took care of 8 months ago now. 50-year-old man admitted to one of Penn's hospitals by way of the emergency department for management of pain due to metastatic colon cancer. had severe pain on admission for which a medication review revealed only Tylenol. That's all he was on. Had been admitted 4 times in the last 6 months, twice due to pain, once due to nausea, volume depletion, once due to altered mental status, which in retrospect was probably due to nausea and volume depletion. His wife is clearly, when you meet him in the emergency room, and her very overwhelmed with caregiving, really wants to know about things that would help her care for him. Talking with him later on the floor, one of the oncology floors, was very, very clear that he did not want to be there. Doesn't want to be in the hospital, doesn't want to go back to the hospital. And one thing that's really telling is that last sentence, that every time you get to the hospital, you get worse. You get more tired, you get weaker, bad things happen. He didn't actually say that, but I would, and many of you are nodding, you all agree. The one place we all want to avoid, whether we're patients ourselves or family members of patients or healthcare providers, is the hospital. Things don't happen well in hospitals. And his wife knew that. And that was the real tragedy of this story. The way he got to the hospital, which many of you probably had begun to guess, was that he developed pain that was severe. His wife didn't know how to help him, called the oncologist. The oncologist was out of the country. The oncology fellow was willing to help but didn't have a DEA number. She tried calling friends, neighbors to help get him to a clinic. Nobody was available, so what did she do? If you had a husband who was suffering, needed help, had no way to get him to a clinic, call 911, right? So that's what she did. So she called 911, the ambulance crew came, picked him up, took him to the emergency room, wound up in the emergency room. In theory, he could have gotten a prescription for oral morphine and gotten sent home, right? But once you get to the emergency room, what happens? Somebody gets x-rays, somebody gets a CAT scan, somebody certainly gets blood tests. And you've got a guy with metastatic cancer in the emergency room. Once you start getting blood tests, right? You have a low potassium, you have a high sodium, you have a low glucose, you certainly have a low hemoglobin, high calcium. I've just listed 5 reasons for him to be hospitalized, and so he was. So you have a guy with pain who wants to avoid the hospital, who winds up in the hospital for pain management. Just to give you a sense of how broken our healthcare system can be. So here's where I'd like to go in the next 40 minutes or so. I'd like to talk briefly about some of the challenges from the health system perspective of patients like John. How do we do a good job of taking care of him and patients like him, and sometimes how do we fail, as we did arguably in John's case. I'll try to convince you that we need to be thinking much more as a health system about home-based palliative care. I'll talk a little bit about hospice as one way of providing home-based palliative care, and then I'll turn that around and try to convince you that although hospice is a partial answer, it's not all of the answer, it's not where we need to be. And then I'll start talking about an alternative, including the CLAIM project, the CMS Innovation Project, and I'll tell you a little bit about that as a way of providing what we hope is relatively comprehensive palliative home care for patients, and then I'll show you some results that we're getting out of year 1. So again, trying to toggle back and forth between the story at a one-on-one level and then some data and research on the other. So challenges of chronic serious illness, we saw pretty much all of those in John's case. For health systems, though, patients like John are also challenging. 30-day readmissions, poor satisfaction. A lot of the things that happened to John were incredibly stressful for him and his wife, but they're also, in a different way, stressful for health systems. And you could argue that we really shouldn't be thinking about these. We shouldn't be thinking about these 10,000-foot level issues. What really matters is what's on the left-hand side. What really matters is what is important to patients like John and his wife. As the Christiana motto has it, what happens to our neighbors and how they feel and how they experience healthcare. And I think that's true. But as one of my roles now as Director of Hospice and Palliative Care for the Penn Health System, I need to think about stories like John's, but I also need to think about how to message stories like John to people like Ralph Muller, who's the CEO of the Penn Health System. How do I use a combination of stories and data to convince him that we need to build palliative care? And so I've really begun to think of the things on the right side of the slide as kind of the flip side of what John and his wife experienced. not more or less important, but important in a different way. They're leverage. I mean, those factors on the right side of the slide, that's what I use every day to convince my colleagues, to convince leadership at the University of Pennsylvania that we really need to invest in palliative care. I'm not saying that stories don't matter. Stories do matter, but ultimately what our leadership also wants to see is ways that we can improve satisfaction, ways that we can decrease 30-day readmissions, and some of these other outcomes. So where do we start? If we wanted to start thinking about how to help a patient like John specifically, and this is the focus of where I'd like to go in the next half hour, especially if we want to focus on how to help him stay at home comfortably and safely, where do we start? Any idea who this is? Willie Sutton. I never would have recognized him, but some of you did, right? So this is Willie Sutton, who apparently, story has it, when asked by a biographer why he robbed banks, said that I rob banks because that's where the money is. It turns out, by the way, that later in his life he actually clarified and said, that's a great line, I wish I had come up with that, but I didn't really say that. I really rob banks because I like it. But this is actually much more useful for this talk, so just focus on that for a moment. So where is the money when you're talking about patients like John? Again, I don't mean to dismiss the suffering that he and his wife went through, but again, thinking in terms of leverage, thinking in terms of value, thinking in terms of a value proposition for palliative home care, where is the money? The money, I've begun to realize belatedly, I think, as I get more into an administrative role, is in that transition. It's those patients who spend all of their time at home and who occasionally flip over, as John did, and wind up in the hospital. There are opportunities for cost savings by reducing length of stay, certainly by getting patients out sooner, and to some degree by reducing 30-day readmissions. But the real opportunity is taking this population of home care patients, this population of patients like John who are happy at home, want to stay at home, want to avoid the hospital, and keeping them out. That's the big opportunity for cost savings. The other reason, by the way, to help people stay at home is that's where, as I alluded to before, that's where we all want to be. Good data from some work that Joan Tino's done in a national mortality follow-back study, the first reference here, quality of end-of-life care. In general, family members tend to be much more satisfied with care when that care happens outside of a hospital. In fact, the worst place to die, if you look at her data, is in a hospital. That's changing due to the work that Diane and many others have done to build palliative care services in hospitals. But in general, think about where you would want to spend your final days. Think about options that are available to you. Develop a list. And I'm pretty sure that a hospital would not be on the top 10 of that list. The other data, unrelated to palliative care, but I think very interesting. I've gotten very interested in reading lately some of the literature on hospital-at-home programs. And the data are mixed. You know, some hospital-at-home programs save money, some don't, some have better outcomes, some are about the same. But the one common theme that runs through a lot of hospital-at-home programs is satisfaction. Outcomes may be different, costs may be different, but patients generally like these programs because these programs help them to stay at home. I'm not saying that's the only benefit to hospital-at-home programs, but that's one that stands out pretty clearly. And our pediatrician colleagues have known this for years. They know what John realized a long time ago, that kids do worse when they come into the hospital, families do worse, dynamics break down. The most helpful thing you can do to a chronically ill child and his or her family is to help him or her stay at home. So our pediatric colleagues have known this for years, which we're just beginning to figure out. So what about hospice? Just a show of hands, how many people here are from a hospice organization? So many. And I am too. I'm the chief medical officer of Penn's hospice program. A lot of my research focuses on hospice. I have been and continue to be a big fan of hospice, as I'm sure many of you are. There's actually pretty decent data showing that hospice is effective at achieving many of these outcomes and some that I didn't mention. The data quality are good. We're never going to have good randomized control trial data. Think about how that would work. You'd take some people who wanted hospice and you wouldn't refer them, other people who didn't want hospice and you would refer them. That's a randomized control trial that would be entertaining to hear the IRB discussion of, but it's not one that I really want to propose. So most of the data we have are propensity score matched case control studies. or some combination. So decent quality data, but not perfect. In general, though, those of us who either work in hospice, refer patients to hospice, are pretty convinced that hospice has a lot of value to bring to the table. Hospice, though, isn't necessarily the best solution for every patient at every stage of illness. And I love this flowchart because it summarizes what a lot of healthcare leaders think. As I realize as I'm talking to them, this is kind of the way their brains process information. You take a complex problem, you break it up into a couple of key components like does it move, should it move, and then that produces a solution that involves either WD-40 or duct tape or some combination. And I find that whether you're talking about decreasing surgical mortality rates, improving rates of 30-day readmission, improving satisfaction, many healthcare leaders tend to think in terms of WD-40 and duct tape. And to some degree, I think that's often the way we think of hospice. Patients need better palliative home care program. We have hospice, therefore we need to get more patients into hospice sooner, which we do. I mean, our median length of stay in our hospice in Philadelphia is only about 6 days. And we have 20% of our patients referred in the last 24 hours. So I'm all in favor of getting more patients in the hospice sooner, don't get me wrong. But that's not the ultimate solution for all patients. And the best data to support that, I think, or if you look nationwide, our numbers at Penn's Hospice are pretty bad in terms of length of stay, but nationwide they're not that much better. So nationwide, the median length of stay these days is only about 18 days. About a third of patients are referred in the last week of life and 10% in the last 24 hours. I don't know what the optimal length of stay in hospice is, but for those patients who enroll in hospice in the last 24 hours, at least in our hospice, that often means a patient referred from one of our hospitals to our hospice unit, somebody who dies in the ambulance, bouncing over potholed Philadelphia streets between our hospital and our unit. That's not an optimal length of stay. Those patients either should have been referred much sooner or they should have had access to an alternative, but that's not good care. We could talk a lot about why that happens. Why patients are referred to hospice so late. A lot of it has to do with the degree to which we all deny death. Nobody wants to think about end-of-life care. But a lot of it, frankly, has to do with hospice eligibility criteria. Patients need to have a prognosis of 6 months or less if the illness runs its usual course, and they must embrace a plan of comfort care, which isn't specifically defined based on hospice's interpretation of regs. On the other hand, what that means generally is a focus on comfort care, at least for that admitting diagnosis. For many patients, these criteria work very, very well. But for many, they don't. And for a patient like John, they didn't. Didn't want to be in the hospital, but still wanted some aggressive treatment. And there's a picture of a typewriter there, which you're probably wondering about. The story goes that back in the 1870s, as the Underwood typewriter company was just getting going, they started building typewriters, they started selling typewriters, people started buying typewriters, people loved their typewriters for the first week. After the first week, after they had a week of experience in typing, they got better at typing. They got better, they got faster, and as soon as they got faster at typing, once they exceeded 20 words a minute or so, then the keys started jamming. And it was at that point that people decided they hated their typewriters, and they started shipping their typewriters back because everybody wanted a typewriter, but nobody wanted a typewriter that would jam if you typed too quickly. So the engineers who worked for Underwood, led by a guy named Christopher Scholes, scratched their heads to try to come up with a solution. Technically, they couldn't figure out how to keep these keys from jamming, but Christopher Scholes came up with a great idea that bypassed all of the technical issues. Any idea what it was? The QWERTY keyboard, right. So if you can't get your keys to type quickly, then you get users to type more slowly. And if you put frequently used keys far apart, if you make the keyboard as inefficient as possible, then people's typing speed goes down, keys don't jam. Obviously that's silly now because we all have electronic keyboards, but we're stuck with a keyboard developed 100 years or more ago, which is designed to be 20% slower than more efficient models. And I would argue that's pretty much what happened with the hospice Medicare benefit. David Stockman, who was Ronald Reagan's budget director, was worried that the hospice benefit would break the bank, that everybody would enroll in hospice. So what did he do? He created the equivalent of a QWERTY keyboard, right? Prognosis of 6 months or less, that knocks out a bunch of people. Must accept a plan of comfort care, that knocks out a bunch more. Effectively, you've slowed the equivalent of our typing speed in terms of hospice referral, and now you have people referred in the last days, sometimes hours of life. So David Stockman was happy, but we're stuck with this model that causes us to refer patients late and probably causes us to avoid referring patients who could benefit. You could ask, though, whether David Stockman was onto something, right? So those criteria slow referrals, those criteria delay referrals, but what if David Stockman was right? What if those criteria, prognosis and desire for comfort care, identify the patients who need hospice the most? Then some of those numbers that we're seeing, delayed referrals, low incidence of referrals, maybe that makes sense. Maybe we are getting the patients who really need hospice. I didn't think that was true, but I didn't really have any way of defining that. So some colleagues and I at Penn began a study a couple of years ago that was designed to try to figure out whether hospice eligibility criteria work. A couple of different versions of the study. What I'll show you now is just a cross-sectional study with patients with cancer and then family members. There was also a longitudinal component, which I won't talk about. Patients in the Penn network, and we talked to patients and families if physicians thought, their oncologists thought, that the patient would have a prognosis of 6 months or less if they stopped treatment, as close as we could get to hospice eligibility criteria. We use techniques of conjoint analysis interviews, which I'd be happy to tell you about offline, but essentially they're very simple techniques of marketing research that try to identify the value that patients, consumers, place on various services by asking them to trade off different services. So would you like a nurse or respite care, home health aide, or a chaplain, along with obviously elaborate descriptions of what we mean by those. And then these options would be rearranged and patients would be given another choice and another choice and another choice until we can calculate or model the value that patients, and in this case families, place on each of these. And we could also sum them, right? So you could add up the value that patients and families would put on a variety of services to get some sense of how much they think they would benefit from the program of hospice services, right? So these are the services that we ask them about. You'll notice some of them are classic hospice services. There are a few thrown in there based on focus group testing, like a peer support group or meal delivery that patients, and particularly families, were telling us would be valuable to us, so outside of the Medicare benefit. Any guesses which was the most important to patients and families? Meal delivery, chaplain, visiting nurse, nurse's aide, keep going. Yeah, it was actually telephone case management. And I love this slide because it's, I think, silly, and it's a testament to how broken our healthcare system should be, that when you ask patients and families what extra fancy services would you want, they come up with something like telephone case management, which really should be a standard part of any healthcare system. But this is kind of the icing on the cake that patients and families really thought would be nice to have as a perk. When it really should be standard. So this is the question I posed to you a few minutes ago. Do hospice eligibility criteria identify those patients with the greatest needs? The answer is mixed. So in terms of prognosis, yes, it looks like they do. So again, this is a sample of patients and families with advanced cancer. We found significantly higher needs for the services that I just showed you for patients in the last 6 months of life. So partly, yes. The flip side to that, though, is that the other half of those eligibility criteria, a willingness to embrace a plan of comfort care, doesn't seem to work at all. In fact, in most subgroups, the trend was flipped, meaning those patients who wanted aggressive treatment actually had greater needs. You could think a little bit about why that would be. Our working hypothesis was that patients with cancer who want aggressive treatment are getting aggressive treatment, and aggressive treatment in cancer often means chemotherapy, radiation therapy, often surgery, which results in patients feeling weak, tired, having symptoms. These are exactly the kinds of patients that palliative care can help. So not only does the desire for comfort care not identify those patients with the greatest needs, we're actually probably steering people incorrectly if we're relying on that too much. Jess Fishman, who is a fellow then, is faculty now at Penn, did a subset analysis of this study looking at African Americans and found that African American patients were less likely to have hospice appropriate preferences. They also had greater perceived needs for services, and if you cross those two tabulations, what we realized is that African American patients whose preferences excluded them from hospice actually had greater perceived needs for hospice services than did white patients whose preferences got them into hospice. So not only do hospice eligibility criteria not work particularly well, they're arguably unfair at a population level. So back to John. 54-year-old man, multiple problems. You look at this list and you think about hospice services, visiting nurse, chaplain, social work, case management, involvement of a physician. You look at those services, you look at this list, and you think, yeah, hospice really could help him. Prognosis, though, was uncertain, wants to continue receiving relatively aggressive treatment, doesn't want to be in the hospital, because who does, but wants chemotherapy, transfusions, in particular, EPO, for a variety of reasons, was not appropriate for hospice, or hospice wasn't appropriate for him, the way I usually frame it. So a lot of needs, but hospice wasn't a good fit. So what would ideal palliative home care look like for him? A comprehensive inpatient palliative care assessment, a seamless handoff to outpatient care and to home care, and these sorts of services while he continues to receive the treatment that would benefit him, rational, logical plan of treatment that would probably taper off over time and become less aggressive over time. There's really no way in our healthcare system right now to provide these packages of services. If he enrolls in hospice, he gets a lot of these services, but has to forego treatment unless you have access to an open access hospice program. But without hospice, there's really no way to put that together. So I wanted to tell you briefly in the next 10 minutes or so as we wrap up about a project we have going on now to test what hopefully would be a new model to provide many of the services that hospice provides to patients like John who are not yet ready for hospice. And the conceptual model for claim is based on 3 components. First of all, advanced care planning. Think about John. He had clear but unrecognized preferences to avoid hospitalization. He didn't want to go to the hospital. His wife didn't want him to go to the hospital, but nobody else really knew that. Case management, I don't need to say anything more about that. Patients really shouldn't be admitted to the hospital for what could be managed with oral opioids. And the idea of calling an ambulance to manage pain is just crazy. And then symptom control, the same thing. So we've built claim, we've built the conceptual model on those 3 components. And our pitch to CMS is that if you do a better job at advanced care planning, do a better job at identifying goals for care, better job at symptom management, and most importantly, a better job at case management, you improve quality of care, improve quality of life, keep people out of the hospital, and reduce costs. So in thinking about how to design essentially a program from scratch, the first thing we realized is that we didn't want to design a program from scratch. And so thinking about what tools we had, we really wanted to identify tools, programs that were available. And many of you know the CMS Innovation Grant had a very short timeline for proposals, so we needed to put something together very, very quickly. The story goes that back in the 60s, with the space race between the Americans and the Soviets, they solved on both sides of the ocean a lot of technical problems. One of the most prominent technical problems was one that you could have anticipated, but apparently nobody did, and that is that fountain pens, which were a prominent writing instrument back in the 60s, don't work really well in outer space for obvious and messy reasons. And so the Americans, being the Americans, put a lot of time and effort and money into coming up with a solution. And they created the space pen, which writes upside down and underwater and in zero gravity. The Soviets, though, didn't have a lot of time, didn't have a lot of money, but they did have one thing we didn't have, which is a dictatorship. And when you have a dictatorship, and when you have a group of scientists in a dictatorship, you can take those scientists, you can lock them in a room, and you can tell them they're not coming out until they come up with a solution, which is what the Soviets did. And so the story goes that they locked these scientists in a room on a Friday night, and early Saturday morning, the scientists emerged with an answer. And even better than an answer, they had a prototype. Any guesses what it was? Duh, a pencil, right. So our challenge then in putting this grant together was, what's the equivalent of a pencil? What's something that's a tool we have readily available, easy to implement? What could we take off the shelf and begin to build into a palliative home care program? And we decided to use the Medicare skilled home care benefit, right, which pays for nursing care, primarily nursing care, and some physical therapy and limited social work services for patients who are homebound, meaning they have difficulty getting out of the home except for medical appointments, and who have a skilled care need, which includes many of the needs that are part of palliative care, like pain and symptom management. The logic was that it was an existing revenue stream. There are thousands of home care programs out there, which also means this is scalable. So if we could figure out how to turn a home care program into a palliative home care program, that then becomes something that would be of interest to CMS, hopefully, and something that would be scalable. So our design broadly is to include patients with a primary or secondary diagnosis of cancer who qualify for skilled home care, meaning homebound and a skilled nursing need, comparing claim services versus routine home care using a propensity-matched cohort design matched on some of the variables that I've listed here, with outcomes that include things like pain management, goals discussions, and obviously hospitalizations and cost. Gathered a little bit of preliminary data, and these data are now in press at the Journal of Palliative Medicine. We compared a preliminary palliative home care program, which is basically hospice nurses providing skilled home care. So really no difference except that instead of a home care nurse, you have a hospice nurse. So it's really nursing expertise. Using a propensity score match, providing hospice nurse and 24-hour, 7-day triage. And because of the timeline, we looked at 30-day readmissions because that was data we could get fairly quickly. And we were able to show about a 50% reduction in 30-day readmissions with essentially, I'm simplifying a little bit, but essentially substituting a hospice nurse for a home care nurse. All of the other infrastructure was the same. So just substituting somebody with expertise in goals discussions, pain and symptom management, we're able to cut hospitalizations, 30-day readmissions by 50%. And that gave us some of the juice that we needed to go to CMS and say, well, what if we could add on additional services? Just think what we could do. But which services? Right, this is where it gets interesting. If you want to think about designing a palliative home care program for a patient like John, 54-year-old guy, metastatic colon cancer, lots of symptom needs, caregiver needs, which services would you focus on? So remember, these are the services that I showed you before. We were able to go back and look at our data and try to figure out which services were most important to patients and families. Case management turns out to be a different place on the list depending on how you look at the data, which is why what I showed you before conflicts with this. But this is a quick summary. And the one thing you'll notice that we noticed with some dismay when we looked at this graph is that a lot of the classic hospice services, a chaplain, respite care, a nurse, are really on the right side of the graph, meaning patients and families place less value on them. What they valued most were some of the things on the left side of the graph, things that both aren't part of a standard home care benefit or a hospice benefit and are a little bit more difficult to arrange. It's easy to get a nurse out to see a patient. It's harder to arrange the most popular item, for instance, which is arranging a voucher that lets patients and families pay for a friend or a neighbor to provide care. Not impossible, but harder to do, although much more popular, say, than hiring a home health aide directly. So our challenge was, how do we take these preferences? This is what our neighbors want. This is what patients and families want, and trying to translate those preferences into what we could actually offer. And it was a compromise process, frankly. What I just showed you would be the ideal home care program for patients with advanced cancer. What we put together is what we could put together, which is essentially nurse services and then some of these services listed here. So this is the core summary of what claim offers. We've been looking very carefully at visit frequency, telephone contacts, after hours, emergency contacts, quality of care, including acute care utilization and cost. And just to wrap up, those are the data that I want to show you. Briefly, a couple of challenges we've encountered. The first one is really the biggest one for me, that this is serving such an enormous need, particularly in our health system, we've had a lot of patients come to us who are really, really, really sick. These are patients who even a hospice program, I think, would have difficulty taking care of. But there's really no other option for them, and so they come to us with multiple hospitalizations, with needs like intensive wound care. We're doing sometimes several nursing visits in a day. So these patients really have a lot of needs that are unmet, which is challenging for us to run a program, but really it's more important to me because it makes me realize there's an enormous need out there that's just not being met. Patients are much sicker as a result. It's hard to measure what we're doing in terms of hospice referrals. What I didn't tell you is about half of our patients are discharged from claim to hospice, and their costs, their hospitalizations go way down. It's a challenge to measure that, but I think we need to. And our staff are really having a difficult time. We didn't really anticipate how needy our patients would be. Our staff didn't realize that either, and so I mentioned patients who are getting 2 or 3 nursing visits a day. There are nurses now who have to do 2 or 3 visits a day, and it's a bit of a challenge. But I think we're all excited, and this is all good news. So John was discharged to palliative care, spent the next 4 months, multiple clinic visits, but no hospitalizations, used home infusion twice, and I'm convinced that those home infusion episodes avoided what otherwise would have been a hospitalization. Transition to hospice, was on hospice for 6 weeks. That may not seem like a lot, but again, our median length of stay in hospice is only about 6 or 7 days. So he was on our hospice program 7 times longer than our typical patients are, and was able to die at home, which I don't think he would have been on track to do otherwise. And then family and his 2 daughters got bereavement services from us. So what does the future of palliative care look like? I think increasingly it's going to be home-based, and if we don't keep up with that home focus, we're going to miss out, and our patients are going to miss out. Increasingly needs to be population-centered, thinking less about getting patients out of the hospital sooner, thinking less about keeping patients from returning to the hospital, and really thinking more about the population of patients who are out there right now to try to do a better job at taking care of them at home so they don't need to come into the hospital in the first place. Increasingly integrated with inpatient and outpatient care through electronic medical records and other mechanisms. Increasingly quality-driven. I think we're going to start seeing more focus on palliative care quality, both inpatient and outpatient. And I think, as many of you know, we're already starting to see ways in which palliative care can be funded, and home care in general can be funded by cost avoidance and gain sharing. So thanks to many people that I've worked with, funders in the past, including CMS. Let me stop with this quote because I love it. I'm not a big science fiction fan, but I love this quote anyway. William Gibson is quoted as saying, "The future is here now, it's just not very evenly distributed." I think that works for a lot of innovation, implementation science that I wind up doing, but particularly in palliative care. And I'm willing to bet that somewhere in this room, somebody has an idea for better palliative care that 10 years from now, we'll all look back and say, yeah, this is logical, it's common sense, we should have been doing it this way all the time. So my last plea to you would be, fine, pay attention to me, certainly pay attention to Diane, listen to the discussion, but also look to your left and look to your right and look for ideas that are being harbored by your neighbor, in the outpatient cancer center here, in the community with Hospice of Delaware, Susan Lord's program. Look around for good ideas because this is where good ideas come from. Thanks.
Thank you, David. That was great, and I know there will be some questions and comments that come from the audience during our discussion period. So it's now my honor to introduce Dr. Diane Meyer, one of the leading figures in the field of palliative medicine. Diane is director of the Center to Advance Palliative Care, a national organization devoted to increasing the number and quality of palliative care programs in the United States. She joins us today from the Icahn School of Medicine at Mount Sinai in New York City, where she is vice chair for public policy, professor of geriatrics and palliative medicine, and the Catherine Geisman Professor of Medical Ethics. She founded the Hertzberg Palliative Care Institute there in 1997 and directed it through 2011. Dr. Meyer's accomplishments could be defined by her 2008 MacArthur Fellowship, her more than 200 original papers and books, her service as the editor of the first textbook on geriatric palliative care, and her multiple high-profile awards. And her accomplishments can be defined in quite another way. Under Dr. Meyer's leadership, the number of palliative care programs in U.S. hospitals has more than tripled in the last 10 years. Her influence has been tremendous. The number of patients and families and the number of lives that she has touched is exponential. And a very special and timely congratulations are in order. Just last week it was announced that Dr. Meyer is one of the new members inducted this year into the Institute of Medicine. And as David said, we thought that must have happened years ago, long overdue, but congratulations. So it's really our pleasure now to welcome Dr. Meyer to Christiana Care.
We'll talk about a hard act to follow. David is very self-effacing, but among the most creative, lateral thinking researchers in this area of how do we care for the most vulnerable, certainly in this country and really internationally, and I've been an admirer of your work for many years, and I'm really impressed by your data and can't wait to see the publication so I can start incorporating it in my talks. So what I'm going to do differently than what David did is pull the lens back beyond cancer to really be talking more about what is arguably a much larger population of older adults with functional impairment, frailty, many of whom have some cognitive impairment, enormous family caregiver burden, and a duration of need for palliative care services that is way longer than the patient you saw in David's slide. And what will be really the challenge to your model is will it still save money for people who need it for 4 years? People who are not predictably dying, and possibly people with less intense needs because they don't have cancer. So that'll be the next step, is to apply models that work in distinct patient populations and distinct settings and seeing if we can implement them and bring them to scale in a much more diverse patient population. So what I want to talk about are some of the data on the outcomes of palliative care as focused on this frail, older, functionally impaired patient population, and then talk about models like the one David presented to you and how we go about scaling them. I just want to begin with what I'm sure you are all very well aware of and caution you about how we interpret data like these. These data show that the sickest and most vulnerable patients cost the most. How are those data typically interpreted by the lay press? That we are wasting money on the dying, right? We are blowing the entire society's budget on people who can't get better and aren't going to get better. Think about what that means. We're saying that the most sick don't deserve care because they might go ahead and die. We really need to challenge that cognitive frame. Okay. Of course, the most sick are the most expensive. That's why we have health insurance. That's why we have health systems, to take care of the most sick. So to even begin to contemplate the notion that somehow care spent on people who then go on to die is waste, in my view, is completely immoral and unacceptable, and we need to not accept it. I would then say how we are spending money on people who ultimately go on to die is subject to challenge. But not that these people need care. Of course they do. You and I don't need care because we're not sick. That's why we're cheaper. Okay. So these are Medicare fee-for-service data. On the left-hand side, you see that 90% of Medicare fee-for-service beneficiaries account for about a third of all Medicare spending, at about $8,500 per Medicare beneficiary per year. But the 10% of Medicare beneficiaries who have, in this analysis, 5 or more chronic conditions, and this does not include functional status, by the way, account for roughly 2/3 of Medicare spending. And look at the differential in per year spending. So nearly $50,000 in the 10% versus $8,500 in the 90%. So if you were a health policymaker looking at improving value, what patient population would you focus on? The 90%? No, the 10%. So as David said, we finally have leverage because it's our patient population that has the poor quality and the high cost. It's our patient population that is suddenly of great interest at federal, state levels, and in health system leadership, even though they are outliers in terms of their numbers. They are not the majority of patients that we serve. They account for the majority of spending, but they are not the largest numbers. So I took from David a different patient with a very similar experience. This is an actual patient of ours. We met Mr. B in the ED. They live on 92nd and York on the Upper East Side, which is a old German immigrant neighborhood. She makes all her own clothes, and she always makes a tie to match. When I asked her for a photo, this is the one her daughter from California sent me. So he came into our ED, dementia, admitted via our emergency department through an ambulance for management of back pain due to severe spinal stenosis from arthritis. Not cancer, not something he's going to die of anytime soon, but it sure is making him miserable. And he also was admitted to the hospital 4 times in the prior 6 months. Twice for pain, once for falls, couldn't get him up, and once for delirium or confusion because he hadn't had a bowel movement in 7 days. Okay. So very similar to the patient that David described, turning to the ED because there was no alternative, because there was no safety net in the community, and arguably at even greater risk than your 55-year-old patient was from being hospitalized. His primary caregiver is his wife. Their only daughter lives in California. They have a doorman who is around the building during daytime hours but goes home at night, so there's no doorman after hours, and she was pretty much on her own. He knew enough to know that she was calling an ambulance and was pleading with her not to take him back. He hated being in the hospital, just as David's patient did. Mrs. B told us she called the doctor. It was 7 p.m. on a Thursday night. Of course, the palliative care team was still working when they showed up in the ED. She called the doctor, and the tape said, if this is a medical emergency, call 911. It was the only thing I could do. And this story is pretty much universal in the ED. You know, ask somebody, why did you call 911? They'll say, well, I tried this and that and the other thing, and this was the only thing I could do. And as David said, that's the most important sentence on this slide. It was the only thing the system had in place for them to do. We tend to blame the patients and families for misusing the ED or using the ED for primary care. It's not their fault. It's our fault. It's a system design problem. So where is the concentration of risk? And I'll show you some data that supports this. It's people who are functionally impaired. That is among the most accurate predictors of utilization is functional impairment. People with cognitive impairment have much higher healthcare utilization than people who don't. People with frailty, fatigue, unintended weight loss, decreasing ability to walk a block, and or 1 or more serious illnesses. Now, my patient, Mr. B, you could say that his cognitive impairment was a serious illness, but really what's driving the utilization is the low back pain. Is that a serious illness? I don't know. But it is really adversely affecting his quality of life and hers. So just to show you that I'm not making this up, these are data from Judy Fetter and others published by Avalier Health. And on the right-hand side are the top 5% of Medicare spenders. And then they are divided by number of chronic conditions with or without functional impairment. And among the top 5% of Medicare spenders, 2/3 have functional limitations. Okay. So we all know people who on the list of ICD-9 codes have 5 or more chronic conditions but ride their bike every day. Okay, so they may have mild diabetes and low back pain and a history of a past MI and hypertension. But they're healthy. They're functionally intact. It's not the list, the number of ICD-9 codes that determines need, even though we tend to use that because that's the data we have. It's conditions as opposed to diagnoses. So what happens to us? I mean, I think everybody here knows that you can't get off the planet in the United States pretty much without going through an emergency room 1 or more times and hospitalization and increasingly ICU as well. Alex Smith published these data a few years ago. Half of older people greater than 65 visit an emergency department in their last month of life. Think about it. We know who these people are. How could it possibly be that their safety net is go to the ED? But that's what it is. So when they go to the ED, what happens? They get admitted because something's wrong. And we got to triage them out of the ED really quickly. And thinking about starting someone who's opioid naive on opioids and getting the home care arranged, that's not in the ED mindset for the most part. It's get them out. Quickest way to get them out is send them upstairs. Now, really interestingly, what are the reason for most of these ED visits? It's almost always a symptom. In fact, 9 out of 10 ED visits are precipitated by a symptom. Now, this is not to say that some of these ED visits shouldn't be ED visits, like crushing substernal chest pain in an MI. That's a symptom, but these people should be in the ED. Or, shortness of breath from a PE. But important to note that for many of these ED visits, these are chronic symptoms, like David's patient, like my patient, that really should and could be managed effectively in the community. And as Joan Tino and others have shown, not only is everybody cycling through the ED, not only are they showing up to the ED for things that require good palliative care, but we are increasingly sending people with dementia and extreme old age not only to the ED, not only to the hospital, but to the ICU, including people with dementia. So this is not the fault of patients and families demanding things. This is the only alternative we give them. It's the glide path that we put them on. So we talked about functional impairment. We talked about symptom burden as drivers of utilization. Let's talk about cognitive impairment. These are data from Chris Callahan at the University of Indiana. In his group, he did a prospective study of a cohort of community-dwelling older adults and compared their utilization based on whether they had a diagnosis of dementia or they did not. And look at the difference in utilization. 4 times as much subacute rehab, 20 times more nursing home placement, 50% more hospitalization, twice as much home health, certified home health agency usage, and 3 times as many burdensome transitions. Why do you think that is? Why do you think dementia patients are such heavy utilizers of the healthcare system? They're not calling 911. Why are the families calling? They're home alone, no support. We tend to blame them when they show up with their demented loved one in the ED as abandoning or dumping, but actually we're the ones abandoning and dumping. These are data on how much money we spend on dementia in this country, and this does include total spend. This is out-of-pocket spending. This is days lost from work. This is taxpayer dollars. It's everything in this estimate. $215 billion per year in 2010 dollars. How do you think this compares to heart disease and cancer spending? This is more than heart disease and cancer combined. Okay, so what do you see in the newspapers and the journals? It's all about the high cost of cancer care. The high cost of cancer care doesn't hold a candle to the high cost of dementia care. The 2040 estimates will be about $500 billion. That's my generation. You guys will be taking care of me, all you young people here. With advanced dementia, we're talking about big money here. And this is based on utilization projections from the current state of utilization. So we have to markedly change the glide path, the standard of what happens to this patient population, or we will be paying for nothing else in our society. Not roads, not schools, not public health, not safe drugs, nothing else. Just the care of people with end-stage dementia. So in case I haven't already made you nervous, there's projected to be a 10-fold growth in dementia-related hospitalizations as the numbers of baby boomers get there, and a 3-fold growth in need for community-based support. So hopefully I've convinced you that this is the group we should be focusing on. Those with functional limitation, frailty, cognitive impairment, and or one or more serious illnesses. So this is an overlapping Venn diagram that my colleague Sean Morrison made a couple years ago to basically show that what we need to do is stop thinking about geriatrics and palliative care as separate. The overwhelming majority of patients who need palliative care are old. Most old people don't need either geriatrics or palliative care. They're healthy older adults. They need someone who knows how to manage systolic hypertension, encourage people to eat right, to exercise, to plan for the future. They don't need specialty care in geriatrics and palliative medicine. They need a good doctor, nurse practitioner. But for the group that's frail, that's vulnerable, and you can see the criteria here, they are overwhelmingly elderly. Not all. You know, we've got kids with serious illness. We have 55-year-olds with serious illness. But if you just look at it from a numbers standpoint, the clear majority are not only over 65, many are over 80 and 85. So this is the definition of palliative care that is increasingly being utilized. This is based on public opinion data. So this is not the definition that comes from us, the profession. This is the definition that comes from a random sample of 900 likely voters that was done a couple of years ago. What we did with this public opinion survey research done by a very prominent Republican polling firm in Washington was give people kind of a list of characteristics of palliative care. And on that list was end-of-life care, hospice care, terminal care, the things that we doctors and nurses tend to use to describe what we do. And you'll note this definition was based on what the public ranked as the most important and valued components of palliative care. And you will note that nowhere in this definition does it mention prognosis, 6 months, hospice, death, dying, terminal, having to give up one thing to get another thing. That's policymakers and doctors and nurses talking. That's not patients and families talking. So the word serious illness was markedly preferred over advanced illness. Advanced illness means terminal in the eyes of the public. We doctors and other people tend to think it is a safer term. They're on to us with that term. Eligibility based on need, focused on improving quality of life as defined by patients and families. And by the way, the highest ranked component of palliative care was patients and families. I thought that was really interesting, was that the recognition of that we're all in this together and that there's not one patient, there's the whole unit, was their top ranked characteristic. Provided by a team, that was a very highly ranked characteristic. I thought it would be a negative. I mean, think about the number of people that pass through a patient's hospital room in a 24-hour period. It's something like 67, the number of different individuals, counting everyone. So I thought it would be a negative, but actually it seemed to imply to the public that we talk to each other. And it's true, actually, we do. That works with patients, families, and other health professionals to provide an added layer of support. So it's not the consolation prize for when we take you away from your regular doctor and throw you over the wall to hospice, to a completely strange team at the most vulnerable moment in your life. Who designed that? That we build in forcing people to separate from their trusted long-term doctor when they most need that person. when they most need that sustaining relationship. So this is with your regular doctors, alongside your regular doctors, to provide an added layer of support, any age, any diagnosis, any stage, at the same time as curative and life-prolonging treatments like David's patient, right? This is what people want. And as David pointed out, we have a healthcare system that's sort of designed over here by some policymakers' idea of what people want. But what people want is over here. And we really need to remember that they are the customer. We are not the customer. And start listening. And this is the conceptual shift for palliative care, where rather than give it at the brink of death, when somebody has a predictable prognosis and is willing to have their life-prolonging treatment taken away, it is delivered ideally from the point of diagnosis of a serious illness, with the ratio and nature varying across the course of the illness. So the domains of palliative care, the most important one is this communication skill, this listening. And this is a statement I heard at a meeting, and there was a woman in the meeting who has a 10-year-old developmentally disabled child. And she made a care map that put her and her child at the center of the map, and then showed in all these circles the literally 150 different entities she had to deal with for his care. That each one of us, as one of those entities, has no idea about the other 179. Her full-time job is dealing with the people at the school. It was just breathtaking to see her perspective on the healthcare system, in quotes, that she was accessing for her 10-year-old, who is not dying and will live for a very, very long time, but completely dependent. Physical, emotional, and spiritual distress, patient and family professional communication, and this is what we talked about at Grand Rounds this morning, this essential skill of understanding what matters most, what's most important to our patients and families, and then going from there to design a care plan around what matters most. And then not abandoning the patient when they leave the hospital. And this is what's distinct from, for example, the most rapidly growing specialty, hospital medicine, hospitalists. Until very recently, once that patient was discharged, not our problem. Similarly, if you're the private practicing oncologist or cardiologist and there's a call after 7, your tape says call 911, not your problem, right? Palliative care teams, it's our problem if that care plan, that discharge is not sustainable. So for example, we will often fight the discharge planners who want to get somebody home today, say no, not today, not till the hospital bed is delivered, not till the opioid prescription is filled and on the kitchen table, otherwise he will be back tomorrow afternoon. And so it's understanding that that safe discharge is not optional, it's a necessity if you don't want that person coming back. So as David said, the future of palliative care, it's clearly not enough to have access in hospitals. Most illness, the overwhelming majority, occurs in the community. We need home palliative care without regard to prognosis or goals of care. And so this is the goal: the hospital consult service, the inpatient unit, the outpatient clinic, the cancer center, the outpatient palliative care and primary care practices, nursing home services, and most important of all, provider home visits. And your system, Christiana, I had dinner with some of your wonderful leaders last night, is well on its way to building this continuum so that patients, as they inevitably move through what is often a multi-year course of illness, are going to receive high-quality palliative care wherever they happen to be in the system. So the short for that is palliative care for everyone, everywhere. That's my personal mission. So David talked about, well, everybody here has talked about value. And I'm sure because you have the Value Institute here, you are inculcated in what value is. But many clinicians have never heard the term. Value is quality in the numerator and cost in the denominator. So what's the classic example of a high-value medical intervention? Enormously helps, costs very, very little. Vaccination is the classic example, right? Fractions of a penny per dose saves millions of lives per year. That's a really high-value medical intervention. What's a low-value medical intervention? Something that doesn't do much good and costs a huge amount. Resuscitation. Provenge is my favorite, latest favorite, $9,000 per dose, median gain in life expectancy 17 days. Taxpayer dollars. Did you guys know that the FDA by law is prohibited from considering cost in drug approvals? Okay, anyway, we won't get any further into that. So these are a couple columns on data on outcomes of palliative care in different studies. Quality on the left, costs on the right. So palliative care is the sort of perfect storm, right? Improves quality and reduces cost. Okay. How does palliative care reduce cost? By improving quality. So it's really important to understand, and this is something Don Berwick says, that the cost reduction is an epiphenomenon of improving quality. Okay. Mr. B, 4 hospitalizations, 4 ambulances, 4 ED visits for something that could have much more effectively and with much higher quality been attended to at home, even if there was just an 800 number or a 24/7 number to call. Much better quality. Consequence of better quality, doesn't have to call 911. So it's really important that that distinction is crystal clear in people's minds. The minute people start talking about palliative care as cost savings, as a means to cost savings, we are a death panel. We are not a means to cost savings. We are a means to better quality, and oh, by the way, better quality helps people avoid the ED and the hospital, and we have to get our language very disciplined about that. So this is just, I'm going to show you some studies of high-value interventions that have been proven to improve quality and reduce costs. This is the randomized controlled trial of outpatient palliative care in advanced lung cancer patients done at Harvard that showed that not only was quality of life improved, depression reduced, utilization at the end of life reduced, but shock and surprise, these patients actually lived 2.7 months longer. Let's say, for the sake of discussion, that this study is replicated in places that aren't Harvard and the Mass General Lung Cancer Program in the real world, that it might apply to other patient populations beyond cancer and other types of cancer. For the sake of discussion, let's, for the moment, accept that this is a real survival advantage. If this was a chemotherapy agent, I'd be rich. Everyone would be on it. So what do you think the mechanism of action might be for a life prolongation in association with palliative care? Why would care coordination and support prolong life? I'm trying to get you down to mechanisms. If you're a scientist, you want to say, yeah, that's nice, that's touchy-feely, that's Hallmark card, but how? Actually, how? Does it... Less iatrogenesis, right? If you are, in this case, a lung cancer patient, David's patient, you are immunosuppressed, you are receiving chemo, radiation, your immune function stinks, and you come to the hospital and you get C. diff, you die. Okay. Hospitals are really dangerous because of infection risk, because of medical errors. It's no one's intention to cause harm. But if you don't have to be there, you're much better off somewhere else. So reduced iatrogenesis is one. So ability to complete appropriate medical treatments. If you're not in pain and you're not depressed, you're going to show up for your chemo infusion. You're going to get there for your radiation. So the symptom burden actually makes it very difficult for people to complete a course of treatment. What else? Yeah, so certainly identifying things that, if allowed to simmer along, could kill you, but if they were identified early, like an infection, could actually prolong your life. What else? It's up there. So why would improved quality of life help you live longer? So interesting. I mean, this is so obvious to most people, but if you ask doctors this question, like, What importance is quality of life and happiness to survival? That's like not, we don't believe in that. It's meds, it's, so stress on the whole system. So you see that major depression reduction? It was actually a 75% reduction in major depression. We know from data in virtually every diagnosis in which it's been looked at, dementia, stroke, heart disease, cancer, that depression is an independent predictor of mortality. If you have cancer and are also depressed, you will die sooner than a matched control who doesn't have depression. What the mechanism of action is of depression's contribution to earlier death, not clear. There's increasing bodies of data on the sort of neuroimmunology, whether it's cytokine load. Nobody really knows what the biological mechanism is. I presented these data at a grand rounds in Cincinnati a couple years ago, and for the first time in my life, there was some basic scientists in the audience. That never happens in palliative care talks. Just like they're just in a different planet. So this time there were some basic scientists in the audience, and we were talking about this study, and one of the PhDs in the back stood up and told me about a study that had been published in Cell a couple years ago. And this was a randomized controlled trial of immunosuppressed mice. So they'd been transplanted, they were immunosuppressed. They were randomly assigned to sort of best animal practice, clean cages, the right food, infection control, but they were alone. They didn't have a lot of toys. They didn't have chamois cloths to burrow under. There was no particular attention from the staff in the lab. There were no other mice. The intervention group had a much more interesting environment. They got talked to by the staff. There was soothing music. They had things to burrow into and play with. They had toys, and they had other mice. So guess which group lived longer? 4 times longer. So it was the intervention group, in case anyone's wondering. But the guy said to me, so in my lab, we were talking about this study, and we looked at each other and said, we're wasting our lives. It's interesting that the basic scientists could see that, another drug, a different carbon moiety on a drug wasn't the issue here. It was social. It was social supports. It was quality of life. It was having fun. It was, in mice. They are mammals. They're not that far distant from us. But our whole healthcare system is the control group for those mice. This is the Kaplan-Meier statistic on the survival, really marked improvement in survival in the early palliative care group. This is a RCT from Kaiser, which, as everybody knows, has a single budget, right, for the year. So everything's at risk. There's a budget. And Kaiser can see how much money they're spending in each separate setting. So they did a randomized controlled trial of a home palliative care initiative very similar to David's. The control group got the regular certified home health agency without the hospice nurse, without the added layers of support. And you can see if you just looked at the left, there were 3 times as many palliative home visits as usual care home visits. And if you were running a CHOP, you'd say, well, that's really nice, but who's going to pay for that? Medicare's not paying me for that. We can't do that. But it was Kaiser, so they could see the downstream impact of providing much more intensive home care for people who were not, these were heart failure, COPD, and cancer patients. They were not hospice eligible. Marked reduction in utilization in every other setting. Their return on investment was about 4 to 1. So Kaiser, while we think of it as one system, it's hugely variable across the country. But in general, Kaiser is trying to roll out this home-based palliative care, as the VA has done, across their system. Now, why are Kaiser and the VA doing that? Because their incentive is to bring value. That's, they don't have the choice of charging fee-for-service, and the more they do to people, the more money comes in. That's not an option in that system. So they're way ahead of the rest of the system in recognizing that if you meet people's needs at home, they don't come to the hospital. There's some data now developing on palliative care in nursing homes. This is from Hebrew Rehab, also at Harvard, showing that dementia patients who were hospitalized, who got a subsequent nursing home-based palliative care consult, were significantly less likely to go back to the ED. This is another RCT. I really like this one because it points to what David pointed out, which is the importance of the phone and access on the phone. It's very inexpensive. It's very cheap. This was an RCT of RNs, not advanced practice nurses, RNs doing a telephone checklist intervention with cancer patients who lived in rural Vermont and New Hampshire, too far of a distance from the Dartmouth Cancer Center to drive in. So they were randomized to usual care versus a nurse with a checklist who called preemptively, didn't wait for the emergency, called at some preset frequency using a protocol. And asked things like, how was your pain today? What was your worst pain? What was your best pain? How much meds are you taking? When was your last bowel movement? Are you sleeping okay? And then asks Mrs. Jones, the wife, how are you doing? Have you had a break? When are you going to run out of pain meds? The obvious stuff that leads people to the ED. And this was a pretty small study, only 322, again finding with just a telephone intervention, better quality of life, less depression, lower symptom intensity, and with a P of 0.14, an interesting trend towards better survival in the intervention group. Marie she just moved to the University of Alabama. She's just analyzing data on a larger R01 of the same model. And I am waiting with bated breath to see her survival data. Because if this improves quality and reduces cost, this should be universally available. And it's exactly what David said earlier. What do we know about the failure to refer to appropriate support services earlier? This is very important data from the Coping with Cancer study, again from Harvard, from Dana-Farber, that looked at the family consequences, the survivor consequences of business as usual in our hospitals and ICUs, and found that family members of patients who died in an ICU had a 5-fold increased risk of post-traumatic stress disorder as compared to family members of people who died at home on hospice. These are huge social costs that we don't count. We count the patient costs on claims data. We don't count the ripple effect of the harm to families and family systems from this. And also those who died in hospital, their loved ones had a nearly 9-fold increased risk of prolonged grief disorder. So arguably, this in some ways is the largest cost of business as usual in our hospitals and health systems. And the New Yorker, I could have just showed you this and sent you home. Good luck with the American healthcare system and the drugstore. These are a couple studies on the cost side of the value equation. This was an 8-hospital study done by Sean Morrison that showed an adjusted net savings of $4,908 in direct costs per admission for people who died in hospital compared to people with palliative care who died in hospital versus without. And the cost savings was something like $2,700 per patient who got palliative care and was discharged alive. And interestingly, this finding, this cost differential of hospital palliative care has been replicated with high fidelity in terms of the amount saved in multiple other studies, which is surprising to me. But we did a very similar study looking only at Medicaid beneficiaries in 4 high Medicaid penetration hospitals in New York State and found even larger cost savings against the myth that the poor don't want palliative care, that the poor will reject palliative care. That is not the experience in these 4 hospitals. And it is a matter of trust and relationship. And if the quality of care is good and people trust and they're listened to, they're just as likely as any other group in society to accept care that is focused on what is best for their loved one. This is a geriatric model that I think we should all be looking at. It's called GRACE. It was developed by Steve Council, also in Indianapolis. And this is focused on duals. So people with both Medicare and Medicaid, a very high cost, high risk, vulnerable population. Their model, similar to the one that David described, only this one uses an advanced practice nurse. And they've, again, found improved quality of life in the patients and families and a $1,500 per member per year savings. This is hospital at home data that David referred to that was developed by Bruce Leff, a colleague of yours from Johns Hopkins. And this actually has had multiple randomized controlled trials, had a Cochrane analysis, found not only that patient satisfaction was better, as David pointed out, but a nearly 40% reduction in 6-month mortality. Again, if this was a chemotherapy agent, we'd be rich. It would be everywhere. But it's a system of care innovation, so it's nowhere. They also found total spend net of program cost reduced by almost 20%, and then this was mediated by reduced length of stay and reduced imaging and lab testing. So this wasn't everyone who came to the ED who's eligible for hospital at home. You know, there had to be family support, had to be someone who didn't look like they were going to need the ICU. There are criteria for hospital at home. But a very large number of people that we admit, because we have no alternative, would be much better off in terms of survival, getting their care at home. So payers have figured this out. If you're a payer, you want to do anything you can to keep people out of the most expensive setting. If your only concern is your shareholders' return on investment and not quality of care, just looking at it from a straight business standpoint, you want to figure out how to keep patients like the one David presented, like the one I presented, out of the ED, out of the hospital. And if you look around the country, it's commercial payers, both those supporting Medicare Advantage programs, those investing in Medicaid long-term care programs, those working with accountable care organizations that are very hot on home-based palliative care because they see which side of the bread their butter is on. That if you manage the sickest 5% at home effectively, many of them will not need to go to the hospital. And we've talked to you about a couple of cases. And here's just one example. You guys have heard of DaVita. It's a huge multi-state for-profit dialysis company that's making lots and lots of money on taxpayer dollars. They just bought something called Healthcare Partners, which is a house calls program, very similar to the wonderful house calls program you have here. And they are making a 15% positive margin on a full risk per member per month contract. Okay. That's a big profit in healthcare. In some ways, more important than the dollar outcome is the job satisfaction of the doctors working in the system. And I just pulled out this quote from this guy, Dr. Doerr, who was a hospitalist before he started doing this work. Now, instead of 30 to 40 patients per day, Dr. Doerr sees 6 to 8. And he talks about how he looks forward to work now, and he used to hate it because he feels like he's really helping people. So here's just one example of a model very similar to the one David described that I think is the future that's here now, but just not very evenly distributed. And this one is from southeastern Michigan. It was developed by folks at the Hospice of Michigan. Dottie Daramo is the leader there. And she did this in partner with Blue Cross Blue Shield of Michigan, which is by far the largest payer in Michigan and accounts for about 75% of the state of Michigan. So having a dominant payer is an advantage if you're trying to work out system-wide models of care. And so they work with Blue Cross Blue Shield of Michigan, also with 3 different ACOs, 2 of which are pioneer ACOs in southeastern Michigan, and some big employers. And in their pilot data, they found improved quality outcomes, symptoms, quality of life, satisfaction, better family outcomes, and a 30% net total spend savings, net of program costs. Now, I think it's important to note that their targeting of patients is very disciplined. So they do not take care of people with serious and persistent mental illness. They do not take care of substance abusers. They do not take care of homeless people. Their perception is their model will not help those people, that the needs of that patient population is completely different than what a medical model can provide. So they sort of engineer their success in a way by making sure that they are matching their intervention to a population that can actually benefit, and there's a take-home message in that. So they get this feed from Blue Cross Blue Shield of Michigan of people with high utilization and high-risk diagnoses, but they don't stop there. They then put them through an analytic process, and they find out about functional impairment. They find out about cognitive impairment. They find out about family burden. You don't get that from claims data. And then they determine eligibility. They have the most important thing that they do, and the thing that gets the most utilization is the 24/7 access to a phone number, so that instead of calling 911, they can reach an RN who has access to their electronic medical record and can talk them through what to do. They also put transition coaches in the ED and the hospital because there's so many screw-ups between the institution and the next setting. And they have, as a small component of what they do, the ability to send someone to the home to give IV fluids, the ability to send someone to the home to give a shot of an antibiotic. They can do that 24/7. They don't do it much because they find that most of that need is obviated by being able to reach someone on the phone. So here's a whole bunch of models that have been proven to improve value. The point I make on this slide is that we do know what to do, we're just not doing it. Okay. There is a ton of data on models that have been proven to improve quality and reduce costs, but we act like they're not there, and we don't seem to know how to execute on them as a system. So I just want to talk about the key characteristics, because you've got a very insightful, visionary system here that is really focused on value as a system and as a community. I wish every system I visited had this kind of leadership. So you're ahead of the pack in terms of recognizing what needs to happen and what's important. And I just want to point to what I've pulled from the literature as the key characteristics of effective models. So payers understand this, that the highest risk, highest cost patients require high cost interventions to keep them out of the ED in the hospital. The provider side doesn't seem to understand that in the same way. It costs more. You got to invest the resources adequate to the problem if you want people not to have to call 911. So, and fortunately, as David pointed out, now that more and more systems are accepting risk, whether it's Medicare Advantage or becoming an ACO or 30-day readmission penalties or hospital mortality penalties, systems are realizing they have to invest in order to save. This is just an example of a targeting mechanism. This is a frailty index, mild, moderate, and severe frailty, and the Kaplan-Meier survival statistic. People with mild and moderate frailty, 80% are alive at 1 year. People with severe frailty, 50% are dead at 1 year. So one of the characteristics you would look for is frailty as a way of predicting who needs this high-cost intervention, who doesn't. This is a really important study done by a Catalonian Spanish colleague of ours named Xavier Gomez Batiste, who published in BMJ Supportive and Palliative Care, and he did a survey of all the primary care docs in Catalonia. In northern Spain, everyone has a primary care doc. Every primary care doc knows who's on their panel and has an electronic medical record, and the question to these primary care docs was the surprise question. On your panel, who would you not be surprised if they died in the next year? And by the way, the surprise question developed some years ago by Joanne Lynn turns out to be quite an accurate predictor of prognosis. It's better than asking a doctor, when is this person going to die? Because we don't know. And there's a lot of uncertainty. But you could ask me, would you be surprised if this person died in the next year? If I say no, I wouldn't be surprised. These are the patients in these Catalonian doctors' practices where they wouldn't be surprised, and look where the highest proportion is. Dementia and advanced frailty, over half. Not cancer, not heart disease. I mean, they're in there. But the characteristics that these doctors relied upon to figure out who was at highest risk was not a list of ICD-9 diagnoses. So I'm pointing to the importance of targeting, but I don't want to suggest that it's easy. It's not as easy as utilization statistics and lists of ICD-9 diagnoses. And why is it important to target? You know, many of those huge Medicare care coordination demos that failed to show an impact, they did not target. They were providing a very expensive intervention to a population who didn't need it, as opposed to a very high-risk population. So it's critically important not to say, oh, let come one, come all. You will lose your shirt, and you will not be able to show an advantage of the model. So the patient identification and risk stratification are key. We've already talked about the medical characteristics, but the social characteristics are equally key. So if this is a homeless person or a substance abuser or an alcoholic, I can tell you right now that they will be a high utilizer. And if you don't put a social support intervention in place, nothing else that you do will reduce their utilization or improve their quality. Just for your information, the California Healthcare Foundation has a great targeting toolkit for free on its website. They did a really nice job of pulling together all the data on targeting, and I commend it to you. So I think it would be really nice to put in the EPIC electronic health record a series of questions like this that primary care clinicians, nurses, nurse practitioners, doctors answer. Would you be surprised if this patient died in the next 12 to 24 months? Does this patient have decreased function? Have they been losing weight without trying to? Have they had 2 or more unplanned admissions in the last 12 months? Are they a nursing home or assisted living resident? Do they need more help at home? And do they have, or not and, or do they have 1 or more advanced long-term conditions? So targeting, I spent a lot of time on it because I think it is so important to these models. The second key characteristic of successful models is goal setting. And using the word goals with patients and families is a non-starter. Goals doesn't mean anything to patients and families. It's like, what? So the right question is, what is most important to you? What matters most to you? You'll hear things like, I want to make it to my daughter's wedding. You almost never hear, I want to live forever. I have never heard that response to that question. This is a quote from some geriatrician colleagues of mine. And it's interesting to see how the field of geriatrics and the field of palliative medicine are aligning around what have always been the core principles of palliative medicine. So this is Dave Rubin and Mary Tinetti saying in the New England Journal last year, ultimately good medicine is about doing right for the patient, for patients with multiple conditions, disability, limited life expectancy. Any accounting of how well we're succeeding must, above all, consider patients' preferred outcomes. I mean, duh. So this is a great study that Terry Freed did up in New Haven a couple years ago, where she surveyed 357 senior center people and asked them to rank order what was most important to them. That was how the question was phrased, not what are your goals, but what's most important to you. And the choices were staying independent, being free of distressing symptoms, or living longer. And of course, remaining independent was ranked first, and not being subject to overwhelming symptoms was ranked second, and living longer was dead last. How is the healthcare system designed? So, you know, there's a little bit of data. Some is contradictory, some is supportive, but this study found that among Medicare beneficiaries in high Medicare spending regions of the country, the presence of an advance directive was associated with lower Medicare spending, lower hospital death rate, and higher hospice use. And again, from the Coping with Cancer study, just really important data that families who could recall a conversation about prognosis and goals of care was strongly associated with their estimate that their loved one got better care, lower costs, lower adverse psychological consequences for families. So the very thing we think they don't want to talk about, the very thing we are terrified of approaching them with, we feel like we're beating them about the head with a baseball bat, is the thing they need most. They know what's happening. Anyone can see it. Families know. When we don't talk about it, they're going to feel awkward bringing it up because they might think it seems as if they're advocating for their loved one's death. It's our job to bring it up. It's our job. It will not come as a surprise, I promise you, to the patients and families who are living with a serious life-threatening illness that they have a serious life-threatening illness. It will not be news to them. The third characteristic is this recognition. Remember, you mentioned, why is dementia such a high utilizer? It's because the family caregivers can't take it another minute. Okay. And these are data on the number of unpaid hours of care given by non-professional family caregivers, worth about $500 billion per year in current dollars. They are doing wound care. They are administering medications. They are doing things that we require RNs to do in our certified home health agencies. And they have an increased risk of disease, death, and personal bankruptcy. So a huge public health cost of what we burden families with. And I think this is among the most powerful pieces of evidence about the mismatch of how we spend money in our healthcare system. This is a study from Betsy Bradley that was published in BMJ Quality and Safety in 2011, and it shows the ratio of social spending to medical spending in nations across the globe. And you can see in Denmark and the UK, the ratio of social to medical spending is about 2.5 to 1. The United States is the lowest. Okay, our ratio of social spending to medical spending is 0.8. So there's a relationship between these things. We also spend twice as much as our nearest developed nation neighbors on healthcare per capita because we provide no social support. So Mr. B has to go to the ED. David's patient has to go to the ED. It's really obvious and simple. To me. So I love this. This was an analysis of 25 different states that are doing the shift of their long-term care budgets away from nursing homes and to home and community-based services. We know that patients want to stay home, right? There's lots of data on that. So there's been what's called an institutional bias in Medicaid, which is we're willing to pay for you to be in a nursing home, but we're not willing to pay for support at home. But 25 states are trying to shift that bias. And their estimate is the costs of taking care of long-term care patients at home is about a third that of taking care of them in a nursing home. And oh, by the way, that's where they'd rather be. This is really great. This was last week in Health Affairs. That found that if all 48 contiguous states increased by 1% the number of older people who got meals delivered to their homes, it would prevent 1,722 people on Medicaid from needing nursing home care. Social supports. Really simple. And here's a study just on the homeless, and this is, I'm sure, obvious to all of you, that provision of public housing to the homeless leads to marked decrease in health services utilization. So families and communities need help. We've got to mobilize. It's our job to mobilize the community supports, and if they're not there, to make sure they get developed. And the predictors of success of these models is that 24/7 phone access, having the care relationship be with someone from the community, not the different nurse every week from India, but someone who you know by first name, who is a consistent person, who comes to your house, that you trust. That is critical. And that it not be a different person for your heart failure, yet a different person for your cancer, a third person from the home health agency, a fourth person from, the transitional care team. We've got to get it down to one person who is empowered to deal with all aspects of that. And that person has to be trained to mobilize social supports as well as medical supports. So that's the third key characteristic. The fourth key characteristic is what I told you before, that 90% of ED visits in people over the age of 65 are due to symptoms. And that if we don't have teams that know how to manage symptoms, as David's patient, as my patient, they will end up in the ED, very predictably. I love this study from Alex Smith that found that pain of moderate or greater severity that is often troubling is reported by about half of people over age 65 in their last 4 months of life, and the overwhelming majority of the causes of the pain was arthritis, not cancer. We trivialize arthritis pain. It is disabling. It keeps people from functioning. It sends them to the ED. And it's not only pain. This is a study from Lisa Walk, published a few years ago, looking at the symptom burden of community-dwelling older adults. Pain is one, but there are many others. So obviously, the people caring for people at home need to be trained in palliative care assessment and symptom management. And the fifth characteristic is interesting when you think about David's model, and that is that there's a dynamic nature of risk. You see the sine wave. Much of the time, people don't need anything other than that 24/7 phone number and a check-in call every 2 weeks or a month. And that's a very inexpensive model, but it needs to be able to ratchet up immediately if someone gets a fever or has a pain crisis. So we need to be able to dose adjust our community care coordination models, and neither certified home health agencies nor hospice are able to do that under statute. It's one size fits all if you're eligible. And that's insane because disease occurs longitudinally and needs vary. And we're wasting money because of the rigidity of our models. So here's Gomez Batiste again, who I think actually is among the most insightful thinkers about the public health nature of the challenge that David and I have talked to you about. And he's argued that we need to stop talking about terminal disease and talk about advanced chronic or serious illness. We shouldn't be talking about short prognosis. We should be looking months to years. We should shift our focus beyond cancer to all chronic progressive diseases. We shouldn't be talking about diseases. We should be talking about frailty, multiple conditions, functional impairment. We shouldn't be talking about mortality, but prevalence. You know, when we get fixed on who's going to die when, we're missing the vast majority of patients that need us that end up coming to the ED. Not cure versus care, but both life-prolonging treatment and palliative treatment. Not disease or palliation, but disease treatment and palliative treatment. Away from prognosis as criterion over to need as criterion. From a reactive model that waits till David's patient and my patient show up in the ED 4 times in 6 months to finally figure out that maybe we should be doing something differently, to a screening and proactive planned model. From a specialist model, there will never be enough geriatricians and palliative care doctors, nurses, and social workers in 10 lifetimes to meet the needs of all the patients we're describing. We need to get to palliative and geriatric care everywhere. Every clinician needs fundamental skills and competencies. From institutionalized care, nursing home, hospital, to community care. From completely absent regional planning to a public health approach, which your Value Institute gives you a huge step up because that's how you're thinking. And from fragmented care to integrated care. And I actually often close my talks with David's last slide, which I love and stole, about the future is here now, just not very evenly distributed, but because I knew he was going to use it. I got rid of it and came back to another old favorite. Helen Keller wrote this wonderful essay called Optimism, which you can find online, in which she said the world is full of suffering, but it is full also of the overcoming of it. And many of you here are at the vanguard of those efforts. So it's been a real privilege and an honor to be with you. Thank you.